Okay, in this next video for Unit 5, we're going to talk about hypersensitivity reactions, autoimmune diseases, and immunodeficiency diseases. We've touched on hypersensitivity just a little bit previously, and you probably heard of or talked about these, at least some of these autoimmune and immunodeficiency diseases in other classes. So hopefully a lot of the information in this video will be just a repeat or a refresher. Okay, so hypersensitivity is a type of reaction that is an exaggerated response to a typical harmless antigen that results in either tissue injury, disease, and it can even result in death. And then hypersensitivity reactions are classified into 4 different groups. So type 1 hypersensitivity, also referred to as anaphylactic hypersensitivity. So these type of reactions are commonly thought of as allergies. Atopy is an inherited tendency to develop classic allergic responses to naturally occurring inhaled or ingested allergens. Antigens that trigger the formation of IgE are called atopic antigens or allergens. Some examples of these are hay fever. So that would just be like your kind of seasonal allergies, allergic asthma, hives, and systemic anaphylaxis. The distinguishing feature of a type 1 hypersensitivity reaction is the short time span. So it's usually minutes between the exposure to the allergen to the onset of the clinical symptoms. The key immunologic components involved in this hypersensitivity type are IgE antibody, mast cells, basophils, and eosinophils. So during that sensitization phase, the susceptible person is exposed to the allergen. They produce IgE antibodies. The IgE coats the mast cells and basophils. And then during the activation phase, you've got re-exposure to that same antigen, which causes degranulation of the mast cells and basophils, and they release chemicals that induce those allergy symptoms that you might be familiar with. So histamine is one of those chemicals released. The effects of histamine are seen within 30 to 60 seconds. So you've got smooth muscle contraction, which could result in airflow obstruction, vasodilation, which could result in hypotension, and vascular permeability. And then late phase of the reaction, you've got release of secondary mediators from the cells can be seen within 6 to 8 hours after the exposure to the antigen, and they can infiltrate antigen-filled tissue and cause further tissue damage. Eosinophils play a large role in this reaction, and their numbers in the peripheral blood are going to increase, and they release toxic molecules and inflammatory mediators from their granules that are believed to contribute to the ongoing damage that occurs during chronic allergic conditions. Some of the clinical manifestations can depend a lot on the target tissue and the type of receptors that are activated. So skin manifestations, you may see erythema or quote-unquote wheal and flare formation. So that's just kind of welts. There may be swelling and a rash. The systemic response includes anaphylaxis. So this is the most severe type of allergic reaction. It's an acute reaction with simultaneous involvement of multiple organs. So some of the typical products that could induce an anaphylactic type reaction include bee venom, especially wasps, drugs such as penicillin, foods such as dairy, shellfish, and peanuts, and then latex. So some of the testing that can be done for type 1 hypersensitivity reactions, radioimmunosorbent test or the RIST test. This is a non-competitive solid phase immunoassay where you've got anti-human IgE that is bound to a solid phase, such as cellulose, a paper disc, or a microtiter well. You've got patient serum that is added and allowed to react. Then an enzyme labeled anti-IgE is added to detect the bound patient IgE. So the second anti-IgE antibody recognizes a different epitope than that recognized by the first antibody. So that results in a sandwich of your solid phase anti-IgE, serum IgE, and labeled anti-IgE. And that's washed, and then a colorimetric, fluorometric, or chemiluminescent substrate is added. The amount of reactivity detected is directly proportional to the IgE content of the patient's serum. And then in addition to the RIST test, we've also got a RAST test, allergosorbent test. So this is good for detection of allergies to common allergens like ragweed, trees, grasses, molds, animal dander, milk, eggs. It's a non-competitive solid phase immunoassay where you've got your solid phase that's coated with the specific allergen and it's reacted with the patient serum. You've got a labeled anti-IgE that's added. That label is either going to be an enzyme or a fluorometric label. The amount of radioactivity measured is proportional to the amount of allergen-specific IgE that is present in the sample. Okay, type 2 hypersensitivity, also known as antibody-mediated cytotoxic hypersensitivity. So this one typically occurs a few hours after exposure to the antigen. The antigens can be self-antigens or those encountered in transfusions, which are referred to as heteroantigens. You've got binding of antibody to a cell will have one of three major effects depending on the situation. So either the cell is destroyed, the cell function is inhibited, or cell function is increased above normal. Some of the key components involved in type 2 hypersensitivity reactions are IgG, IgM, and complement. So IgG and IgM are produced in response to antigens found on cell surfaces, and depending on the type of cell damage that results, complement could also be activated or antibodies could be produced. So some examples of type 2 hypersensitivity reactions are transfusion reactions, hemolytic disease of the fetus and newborn, and cold and warm autoimmune hemolytic anemias. So some of the testing that we can do for type 2 hypersensitivity, the antiglobulin testing, so that includes your DAT and your IAT. So the DAT detects red cells that have been sensitized with an antibody or complement in vivo. So this is the testing that we perform to detect transfusion reactions, hemolytic disease of the fetus and newborn, autoimmune hemolytic anemia, and drug-induced hemolytic anemias. And then the IAT detects in vitro binding of antibody to red cells. So this is used for the cross-matching of blood so that we can help prevent transfusion reactions. It's to determine the presence of a particular antibody in patient plasma or to type patient red cells for specific blood group antigens. Okay, our type 3 hypersensitivity reactions, also known as complex mediated hypersensitivity. This is usually going to occur a few hours after exposure to the antigen. It's similar to type 2, so it involves IgG and IgM, and destruction is complement mediated, but the antigen is soluble, so complexes that are formed can precipitate out of the blood and deposit in the tissues where they bind, complement, and cause tissue damage. So the tissue sites where these immune complexes commonly deposit can include the glomerular basement membrane, the vascular endothelium, joint linings, and pulmonary alveolar membranes. And the end result of these actions is tissue damage, long-term changes, including loss of tissue elements that cannot regenerate, and the accumulation of scar tissue. So some clinical examples, we have what's called the Arthus reaction. So this is the classic example of type 3 hypersensitivity. You've got rabbits that are immunized to produce an abundance of circulating antibodies. Then they're injected with intradermal antigen, and then a localized inflammatory reaction is the result. So the activation of complement is critical for that Arthus reaction. This reaction can sometimes be seen in humans following booster injections with tetanus, diphtheria, or measles vaccines. And then serum sickness is another example. It's a generalized type 3 hypersensitivity reaction that results from passive immunization of humans with animal serum. So before the advent of antibiotics and vaccines, horse antiserums were used to treat some infections. So with this, you had horses that were immunized with corresponding antigen to provide immunity to humans. It is still used today as a treatment for snake bites, but the patients were exposed to animal sera. They can produce antibodies against the foreign animal proteins to trigger that type 3 reaction. This can also happen after treatment of patients with mouse monoclonal antibodies for diseases like cancer and autoimmune disorders. Some of the generalized symptoms of serum sickness will appear 7 to 21 days after the injection of the animal serum, and those symptoms can include headache, fever, nausea, vomiting, joint pain, rashes, lymphadenopathy. Those reactions are usually self-limiting. Recovery can take a few weeks after the antigen is eliminated, but previous exposure to animal serum can result in more rapid reaction with increased severity. Okay, autoimmune diseases and other causes of type 3 hypersensitivity reactions, systemic lupus erythematosus or SLE, and rheumatoid arthritis. So you've got patients that produce autoantibodies that form immune complexes to trigger that type 3 reaction. So in lupus, immune complex deposition involves multiple organs, but the main damage is going to occur in the joints, skin, and kidneys. In rheumatoid arthritis, immune complexes primarily cause damage to the joints. This can also be caused by other factors, including components of vaccines, bee stings, treatment with certain drugs, especially penicillin and the sulfonamides, and infections such as viral hepatitis and group A strep. Testing for type 3, so the methods can vary and it depends on the condition being targeted or tested for. Some methods that could be used include indirect immunofluorescence, ELISA, fluorescent microsphere multiplex immunoassays, fluorescent staining of tissue sections, latex agglutination, nephelometry, and measuring complement levels. Okay, so just as a note, hypersensitivity types 1, 2, and 3 are all antibody mediated and are known as immediate hypersensitivity reactions because the symptoms are going to develop within a few minutes to a few hours after exposure to the antigen. So they're a little bit different from type 4. So type 4 hypersensitivity is also known as cell-mediated hypersensitivity. It's referred to as delayed hypersensitivity because the clinical manifestations do not appear until about 24 to 48 hours after contact with the antigen, and sensitized T cells are responsible for these reactions. So there's an initial sensitization of 1 to 2 weeks that takes place After the first contact with the antigen, inflammation is enhanced, granulomas can form that cause tissue destruction. Antigens that can trigger these types of reactions are usually either intracellular pathogens or contact antigens. So intracellular pathogens can be bacteria, fungi, parasites, or viruses. So some pathogens that commonly induce delayed hypersensitivity include Mycobacterium tuberculosis, Mycobacterium leprae, Pneumocystis carinii, Leishmania species, and the herpes simplex virus. Contact antigens are those that come into direct contact with the skin. So those include plants such as poison ivy and poison oak, metals like nickel salts, and components of hair dyes and cosmetics. Some of the clinical manifestations of type 4 include contact dermatitis. So this produces a skin eruption characterized by erythema, swelling, and the formation of papules that appear anywhere from 6 hours to several days after the exposure. And the site usually itches. So poison ivy is an example of that. Hypersensitivity pneumonitis. So this is an allergic disease of the lung parenchyma that's characterized by inflammation of the alveoli and interstitial spaces in the lungs. It's caused by chronic inhalation of a wide variety of antigens, and it's most often seen in people who are engaged in work or hobbies that involve exposure to a particular antigen. So examples of that would be farmer's lung, bird breeder's lung disease, humidifier or air conditioner lung disease. So the reaction is most likely caused by microorganisms, especially bacterial and fungal spores, to which individuals are exposed when working with moldy hay, pigeon droppings, compost, moldy tobacco, infested flour, moldy cheese. So those are just a few examples. Symptoms include a dry cough, shortness of breath, fever, chills, weight loss, and general tiredness that can begin anywhere from 6 to 8 hours after exposure to a high dose of the antigen. Okay, skin testing for delayed hypersensitivity. So this is used clinically to detect delayed hypersensitivity responses to a variety of antigens, and the tests are based on a T-cell mediated memory response. So when the antigen is injected intradermally or applied to the surface of the skin, previously sensitized people develop a reaction at the application site. So this type of skin testing has been used to determine allergen sensitivity in contact dermatitis. It's used to assess exposure to Mycobacterium tuberculosis and to evaluate the competency of cell-mediated immune responses in patients with immune deficiency diseases. So an example is the tuberculin skin test that uses Mycobacterium tuberculosis antigen extract prepared from a purified filtrate of the organism's cell wall. So this is called a purified protein derivative, or PPD, where the patient is injected intradermally with 0.1 mLs of 5 tuberculin units of PPD. And then that injection site is examined between 48 to 72 hours after the injection for what's called an induration. So that's just a hardened, raised area. Size of positive is determined by the patient population. So if you work in any type of healthcare job, you've probably had a PPD test done. Another type of testing is interferon gamma release assays, or IGRAs. This is an alternative to the tuberculin skin testing to detect a latent TB infection. So it's based on detecting a cell-mediated immune response by measuring the production of a cytokine by patient T cells that have been stimulated with Mycobacterium tuberculosis specific antigens. So currently there are 2 commercially available types of tests approved by the FDA. And the CDC recommends using either IGRA method to detect latent TB in people who are at high risk of developing active disease. So that would include people who have been recently infected, people with HIV infection or certain medical conditions, and those receiving immunosuppressive drugs, and infants and children under 5 years of age. Okay, autoimmunity. So autoimmunity are disorders in which the immune responses are targeted toward self-antigens, and this results in damage to organs and tissues in the body. Autoimmunity is a loss of tolerance to self-antigens and the subsequent formation of autoantibodies. So we've talked for a while about how the job of your immune system is to kind of constantly regulate and be looking for and identifying self versus non-self antigens, so that if it encounters a non-self antigen, it can elicit that immune response and proceed accordingly. But in autoimmunity, your body kind of loses that ability to distinguish between self and non-self, and it starts seeing self antigens as harmful. So these harmful effects can be caused by T-cell mediated immune responses or autoantibodies that are directed against host antigens. There are more than 100 autoimmune diseases that have been discovered, and they involve various organ systems. The leading cause of chronic illness, autoimmune disorders are the leading cause of chronic illness and death, affecting about 5% of the world's population, including more than 20 million people in the United States alone. Some things that can influence autoimmune conditions could be genetics, hormones. Women are almost 3 times more likely to have an autoimmune disease than men, and then they tend to develop at an earlier age, and women also tend to have more than one autoimmune disease. And then microbial infections, they think, may be a trigger to autoimmune responses. Okay, so we're going to go through a list of some different autoimmune diseases. So systemic lupus erythematosus, or SLE. This is a chronic systemic inflammatory disease that affects between 40 and more than 200 persons per 100,000. Peak age of onset is 20 to 40 years. Women are more likely to be affected than men by a ratio of 9 to 1. It's more common in African Americans and Hispanics than in Caucasians. It appears to originate from complex interactions between environmental factors, genetic susceptibility, and abnormalities within the immune system. Some environmental factors that they think can play a role in SLE include UV light, certain medications, possibly infectious agents. Clinical signs and symptoms are extremely diverse, which seems to be true with a lot of autoimmune disorders. So some of those non-specific symptoms could be fatigue, weight loss, malaise, fever, and anorexia. So those are a lot of times the first symptoms to appear. Joint involvement seems to be the most frequently reported manifestation, because over 90% of patients with SLE have polyarthralgias, which is pain in multiple joints, or arthritis. Skin manifestations are experienced in about 80% of patients, so that can include a rash that could be on any part of the body exposed to sunlight, and the classic butterfly rash across the nose and cheeks, which is less common. There's renal involvement seen in about half of all patients. Testing done for lupus includes the ANA test, or anti-nuclear antibodies, which is considered a screening test. So it's going to be present in the majority of patients with the disease. If the screen is positive, then further tests would be done to differentiate the type of anti-nuclear antibodies that are present. So double-stranded DNA antibodies, this is the most specific pattern for lupus, where you produce a homogeneous staining pattern on indirect immunofluorescence. Antihistone antibodies are associated with drug-induced lupus. You'll see high levels of antihistone that tend to be associated with more active and severe forms of lupus. So these patients typically produce a homogeneous pattern in the immunofluorescence assay. Anti-smooth muscle is specific for lupus because it's not found in other autoimmune diseases, but it's only found in about 20 to 40% of patients with lupus. So it produces a coarse speckled pattern of nuclear fluorescence on the immunofluorescence test. And then fluorescent anti-nuclear antibody testing. This is the most widely used and accepted test because it's highly sensitive. It detects a wide range of antibodies. It's inexpensive. It's easy to perform. So it's usually performed with a 1 to 80 or a 1 to 160 patient dilution. And a titer of 160 or more is generally considered to be clinically significant. So in addition to the titer, the pattern of fluorescence is reported because it can provide clues about the autoantibody present and associated diseases. This just kind of goes over the fluorescent antibody or fluorescent ANA principle of the test. And then these are two of the different types of patterns that you might see in the immunofluorescent testing. So examples of common staining patterns obtained are homogeneous staining of the entire nucleus, speckled pattern staining throughout the nucleus. So this is homogeneous. This is what they refer to as speckled patterns. So when you're doing this ANA test, you're getting, like a positive result, but then there's also a pattern that's associated with that gives additional information. Okay, rheumatoid arthritis is a systemic autoimmune disorder that affects about 0.5 to 1% of the adult population. The prevalence varies with ethnicity and with the patient's geographic location. Usually seen in individuals between 25 and 55 years. Women are 3 times as likely to be affected as men, especially women over 65. Some of the risk factors, genetic factors play a role. Many patients are positive for rheumatoid factor or antibodies to CCP. The strongest environmental risk factor is cigarette smoking, so that doubles the risk for developing the disease. Rheumatoid factor is an IgM antibody to IgG. Pathology, so it's caused by an inflammatory process that results in the destruction of bones and cartilage. Some of the initial symptoms of rheumatoid arthritis involve the joints, tendons, and bursa, which are the fluid-filled sacs around a joint, with some of those non-specific symptoms, such as malaise, fever, fatigue, weight loss, transient joint pain that begins in the small joints of the hands and feet. It can progress to larger joints, which can then lead to muscle spasms, and it can begin to limit motion. Diagnosis. So RF is the antibody most often tested for when making the initial diagnosis. So that autoantibody is usually of the IgM class that reacts with the Fc portion of IgG. So this testing was done by manual agglutination for years. Now it's been largely replaced with ELISA, CLIA, and nephelometric methods. So you've got anti-CCP. A significant number of RF negative patients are positive for anti-CCP, and the presence of anti-CCP usually can precede the onset of rheumatoid arthritis by several years, so it makes it a better marker for early disease. That testing is mostly done by ELISA method. where we've got a specificity of about 95% for rheumatoid arthritis. Autoimmune thyroid disease. So the thyroid gland is essential in regulating the body's metabolism, so it also helps to control the heart, muscle, and digestive functions. It also controls neurological development and maintenance of bone structure. Some of the most notable conditions involving the thyroid are Hashimoto's thyroiditis. This is most often seen in middle-aged women. Women are 5 to 10 more times more likely to develop the disease than men. Patients can develop an enlarged thyroid called a goiter. Patients produce thyroid-specific autoantibodies and cytotoxic T cells. There will be immune destruction of the thyroid gland that occurs that results in decreased thyroid function called hypothyroidism. Symptoms of Hashimoto's include dry skin, decreased sweating, a puffy face with eyelids or eyeballs that'll kind of bulge out, pallor with a yellow tinge, weight gain, fatigue, and dry, brittle hair. TPO or thyroid peroxidase antibodies can be seen in up to about 95% of patients, and anti-thyroglobulin. In Hashimoto's patients, their TSH will be either normal to elevated, but the free T4 will be decreased. Okay, and then Graves' disease is characterized by hyperthyroidism. So that's excessive thyroid function, one of the most frequently occurring autoimmune diseases, and it's the most common cause of hyperthyroidism. Most common in women, by 5 to 1, usually presents in the 50s and 60s. Symptoms of this one include nervousness, insomnia, depression, weight loss, heat intolerance, sweating, rapid heartbeat, palpitations, breathlessness, fatigue, cardiac dysrhythmias, and restlessness. And the patients, about 1/3 of patients will exhibit exophthalmia, which is the bulging eyes. Thyroid stimulating hormone receptor antibodies, or TRAbs, are the main antibodies seen in Graves' disease. And your normal thyroid testing, with Graves' disease, the TSH is going to be decreased or even at undetectable levels, but the free T4 will be elevated. And then you can see anti-TPO antibodies. So then you would measure thyroxine to differentiate between Graves' and Hashimoto's. Okay, celiac disease, which I'm sure all of you guys have heard of. It's been a lot more prevalent in the past several years. It affects the small intestine and other organs. Affects about 1 to 1.5% of the world's population, but that's thought to be an underestimate because a lot of cases go undiagnosed. This disease is unique in that it is associated with a known environmental trigger, which is dietary gluten. Gluten is a protein complex that's found in wheat, barley, and rye. It's poorly digested by some people in the upper GI system. It contains an alcohol-soluble component called gliadin that is resistant to our digestive enzymes. So if there's an increase in the permeability of the intestinal walls, which could be due to an infection or some other cause, undigested gliadin is able to pass through the epithelial barrier of the intestine, and it triggers that inappropriate immune response. So some risk factors for this one: administration of gluten in the diet of an infant less than 4 months old in the absence of breastfeeding, a rotavirus infection, and overgrowth of pathogenic bacteria in the gut. This one also is more common in women than in men by a ratio of 2 to 1 to 3 to 1, and among those who have selective IgA deficiency, Down syndrome, Turner syndrome, or certain autoimmune diseases. Some of the clinical symptoms It can vary by age and by patient, but it's generally going to include diarrhea, abdominal distension, vomiting, constipation. Some older patients can also have neurological symptoms, itchy skin with blisters, osteoporosis, and iron deficiency anemia. So the lab testing that we do, initial testing involves detection of IgA antibodies to TTG or tissue transglutaminase. Confirmation is detection of mysial antibodies or EMAs, which are highly specific for celiac, or a tissue biopsy taken from different parts of the duodenum. HLA typing, it can be useful in differentiating celiac from other conditions, especially if serological tests and biopsy results are borderline. So the absence of HLA-DQ2 or HLA-DQ8 can virtually exclude a diagnosis of celiac disease because people who are negative for these haplotypes are highly unlikely to have the disease. And then the treatment for this one is just a gluten-free diet. Okay, multiple sclerosis, which a lot of times you'll just hear referred to as MS, involves inflammation and destruction of the central nervous system. It affects over 900,000 Americans and millions of people worldwide. Most of the time it's going to begin in young to middle-aged adults, so between 20 to 50, and this one also 2 times more common in women than in men. Some risk factors for this one include inheritance of the HLA allele DRB1 151, reduced exposure to sunlight, which could also lead to a vitamin D deficiency, cigarette smoking, infection with Epstein-Barr virus after early childhood. Pathology, so this one will have formation of lesions called plaques in the white matter of the brain and the spinal cord, which results in the progressive destruction of the myelin sheath of the axons. So you've got an antibody that binds to the myelin membrane, and that can initiate an immune response, which stimulates macrophages and specialized phagocytes called microglial cells. So the cascade of these immunologic events results in acute inflammation, injury to the axons and the glia, structural repair with recovery of some function, and then post-inflammatory neurodegeneration. Some of the clinical symptoms of MS, the patient may have visual disturbances, weakness or diminished dexterity in one or more limbs, locomotor incoordination, dizziness, facial palsy, numerous sensory abnormalities such as tingling or pins and needles that run down the spine or the extremities, flashes of light that can be seen on eye movement. And then lab diagnosis, oligoclonal bands on immunoblotting tests, which is more sensitive than serum protein electrophoresis, IgG index, which is a calculated ratio of CSF, IgG, and albumin, and the serum IgG and albumin. So it's typically elevated and may also be used in making a diagnosis, even though it's not necessarily specific for multiple sclerosis. Okay, myasthenia gravis. This is an autoimmune disease that affects the neuromuscular junction. There's a prevalence of about 150 to 200 people per million, depending on the population. The disease is heterogeneous in terms of its age and onset, age of onset and gender involvement. Early onset myasthenia gravis occurs before the age of 50, affects predominantly females, whereas late onset occurs after the age of 50 and is seen more often in males. So the pathology, you've got an antibody-mediated damage to the acetylcholine receptors in the skeletal muscle or to other proteins in the neuromuscular junction that leads to progressive muscle weakness. So some of the clinical symptoms, the patient, some early signs are ptosis, which is drooping of the eyelids, diplopia, where the patient has double vision, inability to retract the corners of the mouth. This can progress to the more generalized form that involves more muscle groups, which can then lead to difficulty in speaking, chewing, and swallowing. The patient may be unable to maintain support of the trunk, neck, or head. And if respiratory muscle weakness occurs, it can be life-threatening. Lab diagnosis, so about 85% of patients have antibodies to acetylcholine receptors. About 6% of patients have antibodies against muscle-specific kinase, an enzyme that plays an important role in the development of the neuromuscular junction and in the clustering of acetylcholine receptors on the muscle cell membrane. So that enhances the transmission of the signals from the nerve cells. About 2% of patients have antibodies against LRP4, which is a lipoprotein involved in the activation of the muscle-specific kinase. About 40% of patients have antibodies to titin, which is a protein found in striated muscle. Okay, Goodpasture's syndrome or anti-glomerular basement membrane disease. With this one, you've got small vessel vasculitis that's characterized by the presence of an autoantibody to a basement membrane antigen in the glomeruli of the kidneys, alveoli of the lungs, or both. So this is a rare disorder that's found mainly in Caucasians of European origin. It primarily affects two age groups, either men in their late 20s and men and women in their 60s and 70s. Some of the risk factors, so there's really not a whole lot that's known about the circumstances that trigger the autoimmune response in this disease, but there is a strong genetic association. A lot of patients carry the HLA-DRB115 antigen, also exposure to cigarette smoke and other pulmonary irritants, organic solvents, or infection has been implicated in disease pathogenesis by causing tissue injury that exposes the patient's critical antigenic epitopes. So some of the lab diagnosis. So with renal involvement, you would see hematuria, proteinuria, decreased 24-hour creatinine clearance, an elevated BUN and serum creatinine, abnormally shaped red cells, and casts can be seen on the microscopic exam. With pulmonary involvement, the patient's going to have decreased total lung capacity and increased uptake of carbon monoxide. Iron deficiency anemia with decreased H&H can develop. ESR and CRP could be normal or increased. And then anti-glomerular basement membrane antibodies can be detected in the majority of patients. This is done by ELISA method. And then Western blot can be used to confirm positive results or to retest negative samples. High antibody titers are usually associated with rapidly progressing disease. Some patients also can be positive for anti-neutrophil cytoplasmic antibodies, or ANCAs, which might be detectable months to years before the anti-glomerular basement membrane. Histological analysis. So you can do a tissue biopsy to detect tissue-bound anti-GBM. They form a smooth linear ribbon-like pattern of fluorescence along the glomerular basement membrane. Renal biopsy tissue also can reveal crescent formations of inflammatory macrophages in the glomeruli. In this next section, we're talking about immunodeficiency diseases, which are different from autoimmune diseases. So immunodeficiency diseases are disorders in which a part of the body's immune system is missing or dysfunctional. So this can be inherited or acquired because of conditions such as certain infections, malignancies, autoimmune disorders, and immunosuppressive therapies. So primary immunodeficiency disease, so these are inherited dysfunctions of the immune system. Several of the immunodeficiency syndromes show X-linked inheritance, so they're going to affect primarily males. Others show autosomal recessive or autosomal dominant inheritance. There are more than 350 different congenital forms of immunodeficiency, which are the result of specific genetic defects. So some of the diseases, A-gamma globulinemia is a category of conditions in which the main characteristic is deficiency of immunoglobulins. So that includes genetic defects in B cell maturation or mutations that lead to defective interactions between our B cells and our T cells. So X-linked Bruton's tyrosine kinase deficiency affects males almost exclusively, where they lack circulating mature CD19 positive B cells and exhibit a deficiency or lack of immunoglobulins of all classes, and have no plasma cells in their lymphoid tissues, but they do have pre-B cells in their bone marrow. So the patient has small or absent tonsils and adenoids due to those lack of B cells, and the patient is subject to recurrent bacterial infections and subtypes of viral infections. Severe combined immunodeficiency. This is the most serious of the congenital immunodeficiencies. It's a group of related diseases that all affect T and B cell function, but there can be differing causes for that. So the patients present early in infancy with infection by nearly any type of organism. Oral candida, yeast infections, pneumonia, and diarrhea are the most common. Administration of live vaccines can cause severe illness in these patients. Unless immune reconstitution can be achieved by bone marrow transplantation or by specifically replacing a deficient enzyme, patients with severe combined immunodeficiency usually die before 2 years of age. Okay, Wiskott-Aldrich syndrome. This is a rare X-linked recessive syndrome defined by the triad of immunodeficiency, eczema, and thrombocytopenia. This is usually lethal in childhood because of infection, hemorrhage, or malignancy. Some of the lab features of this disease include decrease in platelet number and size with prolonged bleeding time, severe deficiency of isohemagglutinins, which is IgM antibodies to your ABO blood group antigens. They're usually going to have low levels of IgM, normal levels of IgA and IgG, and increased levels of IgE. There will be persistently increased levels of serum alpha beta protein, which is a protein produced in the liver of a developing fetus. So I did that again. Okay, deletion syndrome or DeGeorge syndrome is an autosomal dominant disorder that results from a deletion in chromosome 22, region Q11, which affects thymus development in the embryo. So in this disease, not enough T cells are made, but those that are present are functionally normal. Associated abnormalities include mental retardation, cardiac anomalies, abnormal facial development, and thymic hypoplasia. So the patient has a low number of thymocytes. Patients with a partial deletion have only a minimal thymic defect and near normal immune function. About 20% of children have a pronounced and persistent decrease in T cell numbers and tend to have severe recurrent viral and fungal infections. Ataxia telangiectasia. This is an autosomal recessive syndrome that affects the nervous and immune systems. It's characterized by cerebellar ataxia, which is involuntary muscle movements, and telangiectasias, where you have capillary swelling that results in red blotches on the skin. And this is especially on the earlobes and conjunctiva, so around the eyes. The majority of patients exhibit increased levels of serum alpha-fetoprotein, have a combined defective humoral and cellular immunity and antibody response to antigens, especially polysaccharides. Levels of IgG2, IgA, and IgE are a lot of times either low or absent. The number of circulating T cells a lot of times is decreased. The genetic abnormality results in impairment of DNA repair, so that can lead to an accumulation of genetic mutations. Chronic granulomatous disease. This is a group of disorders that involves inheritance of either an X-linked recessive or autosomal recessive gene that affects neutrophil microbiocidal function. So there's molecular defects that result in an inability of the patient's neutrophils to produce the reactive forms of oxygen necessary for normal bacterial killing. Symptoms of chronic granulomatous disease include recurrent suppurative, which is pus-producing infections, pneumonia, osteomyelitis, draining adenopathy, liver abscesses, dermatitis, and hypergammaglobulinemia. So it's usually your catalase-positive organisms such as Staph aureus, Burkholderia cepacia, Chromobacterium that are involved, and fungi such as Aspergillus and Nocardia. Infections usually begin before the patient is 1 year old, and a lot of times these can be fatal in childhood. More recent testing for this disorder has been through flow cytometry. Okay, and then lastly, complement deficiencies. So complement consists of a series of proteins that work in a cascade to assist antibody in the destruction of cells. So you can have some deficiencies in the early complement components, C1q, C4, and C2. Those are usually going to be associated with a lupus-like syndrome. C2 is thought to be the most common complement component deficiency. C3 deficiency may also have a lupus-like clinical presentation, but it's more likely to involve recurrent infections with encapsulated organisms. C5 through C9 deficiencies are associated with recurrent Neisseria meningitidis infections. C1 esterase inhibitor deficiency is found in patients with hereditary neuroangioedema, and the most complement deficiencies appear to be inherited in an autosomal recessive manner and are likely caused by random changes in the DNA nucleotide sequence. Okay, so that was a lot in this lecture. A lot of autoimmune and immunodeficiency disorders, and then the information on hypersensitivity. But like I said, hopefully some of this will be kind of a refresher for you. And then the last lecture for Unit 5, we'll be talking about transplant immunology and molecular testing.